Hello everybody, welcome to this second day of the Credibility of Science, Expertise and Decision-Making Symposium organized by Anses in France. Anses is the national agency which is dedicated to assessing sanitary hazard in the field of food, environment and labor in order to inform the decision makers. Now, of course, you know that how much we live in the midst of a pandemic that killed 2 million people as of today in the world in less than a year. It took a huge toll on our economy and disrupted our lives. Governments had to take very tough and important decisions throughout the world. I'm talking about lockdowns, curfews, mask mandates, social distancing, funding microbiology, biological, epistemology, vaccine research, mass vaccination programs, relief programs, you name it. There's so much at stake here. In order to tackle this pandemic and its economic, social, and even political consequences. And for most of these incredible decisions that had to be made, experts have been consulted by the decision makers, and many of their recommendations have been followed. Now, today with our three guests, we will try to describe and understand what are the mechanisms of expertise in times of a worldwide sanitary crisis, and what were the interactions between experts, decision makers, and the people as a whole. And we are going to have a whole 2-hour session dedicated to this very COVID-19 worldwide crisis with three guests. Hilgartner will be here with us. He has made an international comparison regarding the way various countries in the world reacted to the COVID pandemic. He's from Cornell University. We have Bourgain from Inserm here. She will discuss modeling in the age of COVID-19. And Benamouzig here is here as well. He is a social scientist from CNRS, and he is involved in the scientific committee which advises the French government regarding the corona crisis. So they will make 20-minute speeches, and then we will have a whole Q&A session, and I will take your questions. So please feel free to ask them right now and throughout all this session. To do that, what you can do is just use the hyperlink, which you will find in the email that you received, and which told you how to connect to the symposium. There's a hyperlink there. Or what you can do otherwise is just send your question using this email address. That's Anses Symposium 2021 questions@anses.fr. And don't forget the capital letters, please. Hilgartner, you are a professor of science and technology studies at Cornell University. Thank you very much for being with us. Your research examines the social dimensions and politics of contemporary and emerging science and technology, especially in life sciences. And since last May, you have been co-leading with Sheila Jasanoff, who gave us a speech yesterday. You are co-leading a comparative study of 16 countries' responses to the COVID pandemic. And you have been able to draw preliminary conclusions which have been released just a few days ago, just in time for you to share them with us. Thank you very much, and we'll listen to you for 20 minutes now.
Great. Thank you very much. And it is an honor to be speaking to this very interesting and exciting panel. So if I could have the next slide, please. And so I'll begin just with a brief introduction. This study, as Paul de Brem has mentioned, is being led by myself and Sheila Jasanoff. We're the co-PIs on this study, and we also have a leadership team of J. Benjamin Hurlbut, Ona Özgade, Margarita Reisberg, and then there are a large number of researchers involved in this as well. So it's a large-scale comparative study. If I could have the next slide, please, with a variety of disciplines represented, most centrally science and technology studies, other social sciences, and also law, history, and policy studies. We have 16 country teams, that are in the countries, a total of 59 collaborators, 38 research institutions are involved, and funding from the National Science Foundation, Schmidt Futures, and multiple national partners around the world, including the French funding for the French team. If I could have the next slide, please. So the countries that we've included, as you can see, include 6 countries in Asia, 7 countries in Europe, and then Australia, Brazil, and the United States. Next slide, please. So this is a comparative study. And so an important question to ask at the beginning is, why compare different countries? I mean, it's a pandemic, and a pandemic, means that it affects everyone. So why look at nations? And, why not consider it solely at an international level? And the point here is that territorial borders still matter tremendously in the world. National decisions dominate the policy making. That's not to say that the World Health Organization and other entities aren't involved in doing things, multinational pharmaceutical companies and so forth. But the decisions about how to manage the pandemic are largely being made within national borders, and those responses have international implications. And furthermore, the different experiences of the nations are quite different. And so examining what is happening and the responses in different countries provides sort of a natural experiment, some opportunities for learning, which may be helpful for dealing with other crises in the future. If I could have the next slide, please. So I'll move into some findings. Yeah, and the first thing to note is that, as I said, the experiences of different countries differ a great deal. And, we have, through the pandemic, had some rude awakenings. One set of rude awakenings we could think of as myths that we kind of tell ourselves and the realities of situations. So the United States, which was expected to be highly prepared to deal with the pandemic, it was ranked #1 in the Global Health Security Index, is the #1 country in terms of deaths. And the US, which has been a sort of world evangelist or beacon for democracy, is a country in which, in the pandemic, democracy has been under attack. In terms of outcomes, the US has nearly 1,000 times more COVID cases per million people than Taiwan, nearly 2,000, more cases, which is extraordinary. And while you can attribute maybe a little of that to the fact that Taiwan is an island nation and so forth, that 2,000 level difference can't be attributed to that alone. Then also there are big differences in the ways countries have mobilized scientific advice. So a good contrast here is Germany, where the Robert Koch Institute has been an established institution that was the source of most science advice. In the UK, there's a science advisory group known as SAGE that has been providing the government with advice, but the advice became contentious, and a group of people, including the former chief science advisor to the UK government, formed a competing independent SAGE. They call it Indie SAGE or Independent SAGE, that offers contrarian advice. And then the relationship between citizens and the state has differed substantially in the different countries. So in the Netherlands, the government put forward the idea of an intelligent lockdown, which would rely on the Dutch citizen and the Dutch citizen's rationality to take into account the situation and make rational decisions. And that would be contrasted against situations in which there was a strict order to lock down. In Japan, there was a certain degree of blaming the victim. That is, that the people who got COVID would be understood as having brought it upon themselves. And in Singapore, the state was sort of a trusted source of paternalistic advice that people readily followed in most cases. If I could have the next slide, please. So in looking at the pandemic in different countries, we recognized early on that in order to understand how nations responded to the pandemic, you couldn't just look at the public health system. You had to also consider the economy as a system and politics as a system. And further, you had to recognize that these systems are coupled, so there are interactions between them. As Ortwin Wren talked about yesterday, problems in one system can spill over into others. And this is central, I think, to understanding the pandemic and national response. If we could move to the next slide. So to jump to some kind of conclusions first, our study reveals 5 sort of fallacies that are commonly stated, not uniformly believed by anyone, but necessarily, but they're things that are advanced often enough by policymakers and become the basis of policy that it's important to point out that in each case, our study shows the opposite. So the first of these fallacies is that a playbook can manage a plague. And our study shows the opposite. The Bush administration in the United States and the Obama administration after it both had created playbooks for how to handle a pandemic. But what happened, in fact, is that the playbooks weren't applied. Playbooks presume that the performers will play their prescribed parts. And a playbook is only going to function if the key actors agree that it's the right play. And if the politics change, the players may throw out the playbook script and play an entirely different game. So what we found is that in some countries, like Taiwan, they had a playbook from their previous experience with SARS, and they successfully were able to implement it. Germany also had a kind of economic playbook in the economic system based on reunification and the 2008 financial crisis. They'd constructed some scripts to manage the economy well, and that worked out. But in the case of the US, the administration disregarded the playbook that had been worked out using Ebola and played a completely different game. The second fallacy is that in emergency, politics takes a backseat to policy, that people pull together. And our study again shows that, that you can't count on this at all. Emergencies amplify the pre-existing conditions in economic and political systems. So in a society that's polarized, crises aggravate divisions. So racial and economic disparities or political hyperpartisanship, distrust of governing elites, these kinds of things kick in. And we see this in Brazil, India, and the United States. On the other hand, in societies that are more consensual, crises reinforce pre-existing solidarity. So people are able to temporarily set aside differences and support policies for the collective good. And we see this in countries like France, Japan, Germany, Singapore, the Netherlands, and so on. The third fallacy is that it's easy to find indicators of success and failure that are clear and that you can kind of measure outcomes with well-defined objective measures. And our study shows the opposite. The outcome measures are always value-laden, they're always contested, they always erase important features of their context. So, the problem is in part that performance measures are numerous and they're often contradictory, and experts may disagree about which ones are right or important, and which indicators seem most important may change over the course of a crisis. So how outcomes are perceived is going to depend on which indicators are used, and the choice of an indicator for evaluating policies becomes a political decision that is potentially contentious. The fourth fallacy is that science advisors enable policymakers to choose the best policies. And again, our study shows the opposite. In crisis situations, with rapidly evolving knowledge, technical knowledge is subject to interpretation. Experts rarely speak with a single voice. And in many countries, conflicting expert advice becomes the norm, not the exception. And you see this in Brazil, the Netherlands, the UK, the US, and so on. So what we find instead of the experts being the source of sort of agreement around this, trust in official advice correlates with trust in government. So in countries where there's more trust in the government than Germany, say, or is a good example, or Singapore, then you find that it's possible to come to some sort of policy agreement. The final fallacy is that distrust in public health reflects scientific illiteracy. And our study, again, shows the opposite. You get vigorous debates about the facts between experts, and those are not only between experts and lay people. So it can't be scientific literacy that's driving it. And you see this in a number of different countries. And we'll be talking more about models, but estimates, models, numbers, and so forth, come out. They change over time. They're based on evolving data, and so if members of the public are paying close attention to this, what they observe is expert disagreement or experts changing their minds. It's easy in those situations to conclude that the experts don't know what they're doing or that they're overconfident. But that is not something that stems from scientific illiteracy. It may stem from paying close attention. The other point to make is that distrust in public health advice may stem from cultural experiences that people have had with medicine, such as exploitation or marginalization. So again, it's not illiteracy. It may be remembering a history. If I could have the next slide, please. Okay, so as I said before, we looked at the three systems: health, economy, and politics in the different countries. And what we found is that in each of these domains, the pandemic finds weak spots in the social order. It's almost as if, just as the virus finds the pre-existing conditions in the individual body, the pandemic finds the weak spots in the body politic and sort of exploits them. So in health, the pandemic disclosed pre-existing weaknesses, both in countries with high and with low mortality. And so the United States and Singapore illustrate this result very well. The United States, despite its achievements in biomedicine and all its planning for pandemic preparedness, did poorly because of structural weaknesses in the health system. There's a lack of a health insurance system that covers all Americans. There's chronic underinvestment in elder care. There's structural inequalities that produced high vulnerability among essential workers, Black Americans, the poor, and underserved rural communities, and so forth. So the pandemic found these weaknesses. In Singapore, by contrast, there were very few deaths. But if you look at where the cases of COVID occurred, 54,000 of the 58,000 cases that occurred by the end of this year, of last year, occurred among the residents of crowded so-called dormitories that house migrant workers from Bangladesh and India. In the economy, we also find the pandemic exploding pre-existing conditions. So again, to use the US as an example, it swiftly rolled out a stimulus package, but pre-existing conditions like inequalities in wealth, income, and opportunities, and weak protection for labor left millions of people descending into poverty. And in contrast, in Germany, various emergency measures were put in place to avoid bankruptcies and layoffs, but they also subsidized employers to protect jobs and even provided income to freelance workers like freelance music teachers and so forth out of a commitment to solidarity. In politics, you also have the situation that the virus exploits these pre-existing conditions. The U.S., with its deep partisan divisions, had conflicts amplified. And with its federal system, you had conflicts within and between all levels of government, the national, the state governments, and municipal governments, cities and so forth, counties. So, this got, as you know, to the point where right-wing militia members, mounted an insurrection on January 6th, and prior to that, the government, the Congress was unable to agree on a second stimulus package until late in December, at which point something that many people believe is too small was passed. We'll see what will happen with the next administration and whether they are able to produce some unity. Another country that illustrates how the pandemic exploits the pre-existing weaknesses is India, where political cleavages along religious lines gave rise to spurious claims of a Muslim plot being waged via the coronavirus. If I could have the next slide. So, looking across the different countries and the different systems, it's possible, I think, at this point, and we did this in our interim report, to classify the countries based on their different response patterns into three types: control countries, consensus countries, and chaos countries. And this is a very high altitude view. These are ideal types. There's variation within the categories. And also, we can't be sure how things will proceed. Some of the countries may shift into other categories over time. But basically, the idea is that in the control countries, people are generally following public health recommendations. There tends to be high public approval of the COVID response. Taiwan is a great case of showing this. The economic problems are less severe. In the case of Taiwan, they're actually projecting economic growth for the year of 2020. You have low mortality and morbidity and so forth. In consensus countries, you get more negotiation about what public health advice should be, and you get some pushback from the citizenry. But overall, there's enough solidarity in politics that there's some agreement about what to do, and things are not as bad as they turn out to be in the chaos countries. In the chaos countries, you get controversy in all three systems. The interaction of those controversies drives a continued worsening in each case. Political divisions get worse, and you have a poor public health record. And so examples of chaos countries would include Brazil, India, the United States, Italy, and so forth. If I could have the next slide, please. So backing up from this to a little explanatory thinking, one thing that is important to recognize is that to a great extent in the modern state, the public health system operates almost like a state within a state. It's, for more than 100 years, modern states have agreed that a key function of the state is to protect public health. And that in order to proceed with this goal, the public health system needs to be granted extraordinary levels of power, such as the power to demand vaccination or to impose quarantines. And so it's almost as if the public health apparatus enjoys a state-like authority, what Sheila Jasanoff has called public health sovereignty. And from this perspective of public health sovereignty, citizens are perceived and understood as basically biological entities whose bodies and whose behavior has to be controlled to prevent widespread infection in the community. You know, if I could have the next slide. But people are not simply biological entities, as we know. They're also, you know, political subjects. And as many states have discovered, political subjects have pushed back in lots of ways, and they have different ways of imagining their relationship with the state than as one of simply a body to be controlled. So we can classify the two modes of intervention, which you find in the public health system around the world, in two very broad categories, somewhat overlapping categories. But the key is that one of them targets the virus. It views the virus as essentially a foreign invader, and it tries to stop it from entering the country through border controls, maybe internal travel controls as well. It aims at blocking it from getting into the individual bodies through personal protective equipment. And then it aims to, should the virus get into the body, to kill it off with miracle drugs and vaccines. And this approach tends to aim toward technological fixes and has a fascination with the idea of a kind of silver bullet solution, the perfect, you know, one-shot intervention that would bring the pandemic to a close. The other mode of intervention is to target social practices. And in this one, citizens and their social practices become viewed as something that has to be controlled. So you have, you know, they're kind of a domestic threat. The citizen, him or herself, becomes the source of danger. And so you have social distancing, limiting gatherings, mandating various behaviors. Masks are a perfect example. And here, instead of looking for a technical fix, you're looking for citizen compliance. And that's going to be the way that you limit the pandemic. So these two approaches, obviously targeting social practices is going to be much more intrusive into lives. And policymakers often underestimated the extent to which their targeting of social practices would be resisted. And so a key finding of this comparative study is that policymakers need to tailor the design of their social interventions in relation to the salient features of the political context. You know, there's just not going to be a one-size-fits-all political contexts vision of how you should proceed that's going to work. Next slide, please. So just a final point is that the tensions around expert advice and around the degree of public health sovereignty really need to be understood as a constitutional matter, as Sheila Jasanoff discussed yesterday. You know, they're kind of, in the modern state, two constitutions. There's the one that we recognize, the written constitution that we all recognize and that originalists and others point to as the key document that serves to delegate to a few leaders the right to rule the many. But there's a second constitution, and kind of epistemic constitution, through which we delegate to a few experts the right to know and the right to speak authoritatively about what is known. And these two constitutions both are operative, but the second one, the constitution that is about delegation to experts, is less recognized as such. But in the 21st century, expertise has become so central to the running of the world, and not that it's brand new, of course, but it's become so central that really to understand what's going on in these cases, you need to recognize that the 21st century social compact includes both of these forms of delegation, political delegation and delegation to experts, and that these two constitutions, if I could have the next slide, can be either sort of in sync or out of sync. And when they're in sync, you get high degrees of compliance, as illustrated by the picture on the left, and agreement, and people decide to follow the advice coming from political and expert authorities. On the other hand, if they're out of sync, you get a chaos and political resistance. And this picture is a picture of a demonstration held by extreme right militia members in the state of Michigan. And this is a place where a group, 13 people were arrested for planning to kidnap the governor of the state of Michigan over her orders of having to do with masks and lockdowns and public health things. Okay, so that kind of gives you a visual representation of what happens when these two constitutions are working together, as opposed to when they are not. If we could move to the next slide, please. Okay, and the next slide. So I want to just offer a really brief conclusion, and I'm going to offer it in the form of hard truths. And the first one is that misreading the world has high costs. Our study shows that the field of public health as a whole has under-theorized in sociological and political terms the actual world into which its guidelines flow. And it has not paid sufficient attention to recognizing the politics on the ground and so forth. The second hard truth is that trust in science is just not the same thing as trust in public health expertise. Public health, because of its sovereignty, wields power over human lives and bodies that's much stronger than the kind of influence that a new laboratory study, on your typical laboratory study, for example, has. And so asking people to trust public health findings is asking more than to ask them to trust a scientific result. It's asking them to trust and to change and to really go much further than simply trusting a result. And then the third hard truth is that societal resilience is more important than planned public health guidance. Preparedness depends more on resilience than a playbook, for example. And so the real challenge in dealing with situations like this, not that you shouldn't have any planning, of course, but the real challenge is to find ways to make societies more resilient. And with that, if I could have the next slide. I just want to acknowledge our collaborators around the world, from the 16 core countries, 2 affiliate countries. This study would not have been possible without their extraordinary talent and their hard work, and their intellectual contributions are what made it possible to do this. And the next slide. I just want to acknowledge our funders, the National Science Foundation, Schmidt Futures, the Cornell Center for the Social Sciences, and next slide. If you want to read the full report, here's the URL, and all that remains now is to thank you for your attention.
Insight in your comparative study of 16 countries. Yes, I have a few questions with you, and maybe you, our panelists here, have some as well. You made at least 3 categories, saying they were somewhat control, consensus, or chaos countries. There's you know, some people say that control countries may be more efficient when it comes to tackling the virus. Is it true in your opinion?
Well, I think that the control countries have been extremely efficient in comparison, say, to the chaos countries at controlling the virus. This, stems in part, from solidarity. I should mention that, it's not just that those countries are. It's not the case that all those countries are authoritarian. South Korea, for example, is a control country, and it's a democratically run state. So, it's not that authoritarianism begets good virus control, simply in that way. It's more that if you have a kind of agreement, a kind of trust in the state, if you have that degree of solidarity, it's possible to make decisions that will lead to outcomes that are better in terms of virus control than what you get in a place where every issue, which is the definition of a chaos country, becomes contested. And you have disagreements among all of the three systems.
You told us that a country, of course, could shift from one category to another. Would you say that at the beginning China was somewhat of a chaos country and then become a control country with regards to the way they tackled the pandemic? And my other question would be, okay, the US was in the chaos category. Will it shift to the consensus category thanks to the Biden administration?
Yeah. So first, regarding China, I mean, the interesting thing in China is that, obviously they have an authoritarian government, and authoritarian governments are perhaps good at doing some things and bad at doing other things. And one of the things that they're bad at doing is at listening to criticism and listening to the people. And so, in the case of China, there was at the national level denial of the severity of the problem early on. So you can see that that's a real weakness of that system. And, yes, once they recognized the problem and the severity of the problem and, stopped punishing and refusing to listen to those who were putting forward the view that there was a problem there, they were able to, with military efficiency, crack down and lock down the country, bring in literally the military, institute extensive controls, and suppress the virus. And then using the surveillance machinery that's already part of their system, they were able to then further suppress little outbreaks that happened as they detect them and so forth. They were able to institute without significant pushback travel bans that even included for a time banning return travel from their own citizens. So I think it's important to grasp that all of these, we aren't endorsing one system over another here, but all of them have their strengths and their weaknesses. And the Chinese case, I think, illustrates both for this authoritarian kind of regime. In the U.S. case, it's prediction is a little dangerous, but I don't expect that the U.S. will, suddenly move into a consensus category just because of the change in administration. The problems in the U.S. are deep and long-standing. The political divisions are serious. The weaknesses in public health and the economy and labor protections and things like that are all contested issues. and this won't be instantly erased, I think, by the change of administration. However, that said, I don't want to be a complete downer about it. I do think it's extremely important that we have the change of administration happening, and well, I'll leave it at that.
We understand what you mean. Now, we have a question from a viewer. Here it is. What kind of public policy can foster social resilience? As you said, that one of the important things is to make a society more resilient. I should add that the whole question is, if health planning is not a relevant policy option, what kind of public policy can foster social resilience?
Well, I mean, we aren't saying that public health planning is not worthwhile. What we're really saying is that it's very insufficient. You know, it's far from enough, and that whatever the weaknesses in the society are, the places where there are vulnerabilities, they will be found. I mean, the Singapore case really suggests this very nicely. You've got a situation in which there are very, very few deaths, but, you know, 54 out of 58,000 cases in a particular, you know, setting where that is, you know, weakly represented, you know, in terms of political weight, with crowding, inequality, people who are not cared for because they aren't citizens, you know, they're, you know, guest workers, you know. So the point is that the resilience of a society is going to depend on building systems that protect, you know, vulnerability, protect the vulnerable, make people less vulnerable, that through solidarity and through mechanisms that are going to provide a buffer and a cushion and protect people, these kinds of things are going to be important. So the kinds of public policies that we would say this study suggests are those that will address the vulnerabilities, you know. And then, you know, it's also the case that if we look at the pandemic, you know, this is a national study, but if we look at it as a global phenomenon, it's also critically important that we think about vulnerability on the international scale as well and develop public policies in relation to that. It's going to be very important to recognize that pandemics are global. And while our study is national, you know, the need to not think too nationalistically, you know, is also an important dimension of this. We need policies that will address local and national, you know, internal vulnerabilities, but also don't descend into, you know, things like extreme vaccine nationalism and so forth that just make it impossible as a global society to defeat public health problems.
Catherine Bourgain, who is right here with us and who will be the next speaker, she is a social scientist and she would like to ask you a question, Mr. Hilgartner.
Thank you very much for this very inspiring and I think highly needed comparative perspective. But I was wondering whether you could tell us a little bit more on the types of outcomes that you chose to categorize the different countries, because I was just a bit surprised as a French person to hear how you mentioned the way it's going on in France. So I'm sure it depends on the perspective, and not being in France. So I was wondering whether it was only the number of deaths or the economic GP display, or the, I mean, what kinds of measurement you chose, and what's the sensitivity of your general conclusions on this type of choices?
Yeah, what we did actually, we didn't do it by, we didn't classify them according to outcomes alone. We classified them essentially by studying controversies within the country. So in all of the countries, we had local groups of people who examined the sort of flow of discussion and debate within the country. And we did this at several different levels of resolution. There was a set of I think, 75 questions that we structured as yes or no questions. So, you know, is there a mask mandate? And then the people would answer those questions and also give a short answer of 100 or 200 words or something like that, explaining it. So that way we mapped out what was and wasn't controversial in different countries. We also studied specific controversies in countries, you know, what became debated. And then we also constructed timelines of the development of countries. And then each, you know, you can look in our report, you know, it's an interim report and things may change, but it includes several pages written by the country team on each of the 16 countries that describes what happened sort of overall and in each of the three systems, health, economy, and politics. And so the mapping was not based on, you know, say GDP or things like that, but if people argued about GDP, if they argued about a policy, if they argued about whether an outcome was good enough, if they argued about which outcome was good, these were the things that we took account of.
Catherine Bourgain, you will be our next speaker. You are a research director at the French National Institute for Health and Medical Research, the Inserm, and you are the director of a research center in Paris, which is called the Medicine, Science, Health, Mental Health and Society Research Center, dubbed CNRS 3. You have worked for 10 years now in genetic epidemiology, and you have become now a social scientist. You especially study the epistemology and practices of contemporary human genetics research with an interest in models and healthcare data. And your talk is especially about models and modelers, so we'll listen to you.
Thank you. Right. So it's my pleasure to present and discuss some very primary elements of an ongoing study that we've started with my colleague Luc Berlivet at CNRS 3 during the first phase of the COVID-19 epidemic. So it's a work in progress, and I will try today to sketch some general points that we are interested in developing further in the coming month. In his report published on March 12th, the French Scientific Advisory Council insists on the importance of considering results produced by mathematical models with an attention for their limits and uncertainties. A paper that was just published by Roy Anderson, an epidemiologist from Imperial College London, is particularly mobilized in that report. In this paper that was published in the Lancet journal, Roy Anderson proposes a generic analysis of potential effects of the measures that government could take that is based on a basic modeling of disease transmission and epidemics trajectory that is informed by previous work on past epidemics, notably SARS and H1N1 influenza. The graph that is shown here will have a major impact on the general framing of the epidemic in political debates and decision at large, but also more generally in the public debate. As the French Health Minister Olivier Véran will phrase it, the goal will now be to flatten the curve in reference to this type of graph. The paper also introduces a classic concept in epidemiology of epidemics, the now familiar R0. Indeed, R0 refers to the basic reproduction number, and it is directly related to the overall number of people that may possibly be infected during the course of the epidemic. Yet, as its definition suggests, I'm quoting, It corresponds to the mean number of secondary cases generated by one primary case when the population is largely susceptible to infection. So this is a typically mathematical model parameter whose meaning is totally linked and framed by the nature and the assumptions of the model. And yet, despite this specific model parameter nature, this R0 will turn to be handled as a kind of thermometer for the epidemic. And I present here a map that was published in July 2020 by French National Radio that represents the value of R0 in the different French regions with a graphical format that strongly, of course, resembles weather maps. So the epidemic is stronger in red regions and lower in green ones. This relatively new visibility of models and modeling tools in the media and in the framing of political decisions goes along an intriguing new attention for modelers. Entire pages of national newspapers are dedicated to portraits of modelers. They are invited on radio and on TV shows. In some ways, they have become new celebrities. Like in many other domains, the COVID-19 crisis reveals a largely pre-existing situation. Models are playing increasingly important roles in social, political, and administrative contexts in a variety of fields, the most emblematic one being, of course, that of climate change. At this point, it is probably not irrelevant to start with a simple question. What are we referring to when we mention models? The concept has evolved over time and technotes scientific context. Yet, in its primary meaning, a model is a mathematical representation of reality that is constructed and validated with some observations. It helps evaluating the extent to which a theory can account for the reality. In this sense, it's not a simple theoretical abstraction, but it is a representation of reality that aims at understanding, analyzing, and eventually act upon phenomena. A model is a necessary reductionist approach, and this work of reducing complexity is guided by specific scientific questions, by specific hypotheses and style of thought and practice of modelers. It is also guided by the type of data that are available, these pieces of reality that must feed the model. And in all cases, as summarized by the British statistician George Box, all models are wrong, but some are useful. As Michel Armat and Ami Dahan have analyzed, the rise of computers and increasing capacities of computers have strongly expanded and diversified the practices of modelers. In particular, simulation-based approaches have been developed in which underlying theories are partly incomplete. Indeed, the purpose is no more to understand natural phenomena, but rather to try to optimize their management. In this sense, theoretical ambitions are limited, although this mechanistic ideal of models remains attached to the concept. This evolution of practices is characterized by the production of a new type of anticipations referred to as scenario. Indeed, computing capacities can help exploring the behavior of large and complex socio-technical systems. And in such context, where models are embedded in simulation, the relationship with temporality and with data is complex. Anticipation are highly dependent on the present and past data that have been used to build the model that produced them. Now, in the context of infectious diseases, modeling approaches have been developed since the early 20th century. Notably, in 1927, two Scottish, one physician, other biochemists, Kermack and Mark Kendrick, published a paper in which they proposed a mathematical model to explain the apparent sporadic occurrence of large epidemics. The questions that the model is aimed at answering are: how does an epidemic stop? Is it only when all the population has been infected, or can it stop earlier? How can we explain the observed variability of epidemics across time and places? Under this model, the model proposed by Kermack and McKendrick, all individuals in the population are considered as equally susceptible of being infected. The infection is a random process, and all cases end either fatally or with a complete immunity against the disease. The model produces a dynamic for the epidemic that relies on a simple set of three key parameters that are infectivity, recovery rate, and death rate. And they show that small variations in these parameters can lead to diverging epidemic patterns. So this model is a deterministic approach of the epidemic that seeks to describe the effects on the population with a pathogen that is supposed to remain stable. Its virulence is supposed to remain stable over time as its effects on the people. This model is important because it will have a remarkable legacy under the name of the SEER model, and it remains today a dominant framework for many current models. Indeed, further development will be carried out that will complexify this initial framework in relation to new questions arising, like how to best organize vaccination campaigns for known diseases, like measles, or how to take into account heterogeneous sexual practices for HIV, or specific network connections, or specific transportation capacity for HIV or for the flu. These complexifications go along the new availability of data, whereas the first model was built with a mathematical approach of biology that was poorly informed by data. The turn of the 70s, 80s is characterized by an increase in data, particularly data on epidemics in natural animal population. And by the end of the 90s, this increase in data will meet increasing computing capacities. These evolutions clearly call for a sociological approach to these epidemiology models, with an attention on the modelers. Who produce the models? In which institution are they working? With what kind of knowledge, know-how, and technologies? And what are their objectives? At this point, a small historical precision is required regarding epidemiology. After World War II, epidemiologists mainly focused on non-communicable diseases. So the epidemiology of infectious diseases occupies relatively marginal institutional positions. Expertise in the field has thus developed in a limited number of centers, notably Imperial College and Oxford University for the United Kingdom. So I will now focus on two models and modelers that have been particularly important at the outbreak of the COVID-19 epidemic. The first model is the one developed by Neil Ferguson's group at Imperial College London. Ferguson himself has been involved in policy advisory boards in the UK and in international bodies for a couple of years. The paper is presented as an individual-based simulation model. It takes up the general framework of the 1927 SEER model, as evidenced by the importance of this R0 parameter. but it incorporates a series of refinements that concern the variable probabilities of infection according to ages, to mobility habits using fine-grained national and local census and mobility data. The model relies on simulation of the epidemic process, since exact computation have become intractable at this level of complexity. But the central parameters for the disease transmission model are extrapolated from Wuhan data, because the disease is not known yet. Hypotheses are also made for what regards the infectivity, and the immunity of people is considered as total after recovery. Finally, to evaluate the impact of policy interventions, the model uses fixed characteristics for the disease itself, for instance, for the proportion of asymptomatic individuals in the population, although this parameter is not completely known yet, and for the characteristic of the healthcare infrastructure. Doesn't work? Okay. Some of the critics that have been addressed to this model point out to these characteristics I just listed. For instance, it was said that the model used was built up for the flu with a 13-year-old informatic code. It was said that the code was too complex, messy, and impossible to control and reproduce. It was also said that the model proposes complex simulations that are based on very poor data for what concerns the specificity of this particular disease. And indeed, this is all related to the kind of hypothesis, what is made and implemented in the model and what is not, because of the kind of modeling strategy that has been chosen for this kind of model. And in fact, the effects of the model on the public policies will be contrasted in France and in the UK. It will be used to back the mitigation strategy that was initially adopted in the UK, with adoption of relatively mild measures, whereas in France, it is said to have fostered the decision of the first general lockdown in March 2020. It has been largely pointed out that Ferguson holds a PhD in theoretical physics. Yet, it is a truncated version of his scientific trajectory. Of course, he has a PhD in theoretical physics, that's not the point. But he was also trained and highly socialized in the epidemiology modeling tradition at Oxford and then at Imperial College London, working with Robert May and Roy Anderson, that are two main figures of the epidemiology of infectious disease modeling. And Anderson himself has also served as a chief advisor for the UK Ministry of Defence in early 2000s. Ferguson has been working on missless vaccination strategies or on the prediction of scenarios to optimize control strategies in case of a smallpox attack since the mid-90s. And in 2001, he's a leading modeler of the foot and mouth disease outbreak in UK. And his work is using very fine-grained data on spatial and temporal patterns of disease spreading among farms that were made available by the Ministry of Agriculture. And he used this data to predict further incidence of the disease and simulate effects of control strategies. In these different works, he accompanies a series of major transformations in modeling practices, which correspond precisely to those described by Michel Armat and Annie Dahan. They push the sophistication of models even further to incorporate the ever large set of data available on disease transmission, on human behavior by subcategories, and on the fine effects of control strategies. These evolutions are all based on a set of knowledge and techniques that use new numerical computation facilities. So the configuration is not that of a physicist who would totally reconfigure a domain, but a form of adaptation of practices to the new relationship between theory and data that marks the evolution of the history of modeling and its closer links with questions formulated by policymakers. The second model is the model developed by Mark Lipsich's group in the Harvard School of Public Health, and that was published in the Science Review in April 2020. The model proposes an epidemic dynamic over a 5-year period while considering different situations in terms of duration of immunity, possibility of cross-immunity with pre-existing coronaviruses that are circulating in human population for years, and season effects. So this model incorporates important data sets, notably data from virological testing over time for past coronaviruses epidemic. Globally, the model has a simpler form than that of the Ferguson's group. In particular, the scenarios to evaluate effects of intervention policies incorporate simpler description of the contacts among people in the population. Yet, from its perspective on immunity processes, the paper highlights the sensitivity of the anticipation, the predictions, their sensibility to the actual values of immune parameters. Sensitivity on the duration of immunity in person, on the possibility of cross-immunity. And these are particularly important when we think of mid- and long-term impact of the epidemic. Another consequence, the modelers call for a serological testing campaign to refine the data on that matter. Lipsich and Ferguson belong to the same generation. Their scientific trajectories are different, although they pass through the same point passage, since Lipsich does his PhD in Oxford with Novak and Robert May, the May I mentioned earlier, on the modeling of pathogen virulence evolution. After a postdoc on evolutionary biology of bacteria, and at the US Center for Disease Control, he joins the Department of Epidemiology and the Department of Immunology and Infectious Diseases at Harvard. So his work includes important studies on Streptococcus sorry.
That's a hard one.
In English, pneumonia, including attention on immune response and population biology, and work on pandemic preparedness and response. In 2009, he will serve as a member of the 2009 H1N1 working group of the President's Council of Advisors on Science and Technology. So differently from Ferguson, Lipsich brings attention to pathogen evolution, to immunity into this kind of model. While his work is less directly driven by computational development, they're not absent. Indeed, while calling for more real-time data collection in order to refine the models, he's aware that they require specific skills and knowledge to be able to use this data. Indeed, in a recent commentary on a paper in which data scientists analyze very big mobile phone data with relatively simple models, Lipsich renewed his interest towards this data-intensive epidemiology. To open, maybe rather than conclude, I would just say that models in infectious disease epidemiology are representative of models and modelers in more general setting, and specifically for what concerns the diversification of practices. Simulation-based computer-intensive modeling approaches are rising with the purpose to help optimizing the management of epidemics in response to policymakers. They go hand in hand with efforts to increase data collection and management, yet present data remain imperfect information for anticipating future developments that may still require finer comprehension of phenomena. Further, there is a diversity of practices among modelers that point to different ways of interrogating what is an epidemic and how should it be managed? What should be what is important in the management and what is less important? So analyzing modeling practices and their evolution is, I think, an important task that must be able to take into account the subtleties of practices, including attention to local and national configurations. And I have only spoken today of UK or US modelers, but of course we have in France a socio-history of modelers and models that still must be built. Thank you.
Thank you very much, Catherine Bourgain. I would like to ask you the question of the reliability of models. Is it possible to assess their reliability? What are the criteria that we are going to use when we think of climate change? One could say, okay, they're quite reliable. You know, they told us that temperatures would rise, and they are rising. And so, how can you assess the reliability of these models?
Well, it depends which model you're mentioning, of course, because when models are used to make predictions, well, you can always afterwards, if the scenarios and the measures that the modelers have suggest are indeed implemented the way they suggest they should be implemented, you can always compare the outcome of the measures with the prediction initially, right? But most of the time, when these, in the context of policy making and political decisions, models are used before any kind of checking can be done. So this interplay between theory, simulation, and data is a way that modelers are have found or have developed, try to increase the robustness of their prediction, anticipation. But as I said, it's past or current data, and it's not the future.
On the one hand, when you have into a model as equations, okay, you have been able to modelize the way you know, things are happening, and it's like having a physics equation, right, that you would put into a model. But at the same time, you told me how much it takes practice to build robust models, and how much you know, it's a bit like a cooking recipe, you told me, so that you're able to put a bit more salt, etc. And you are the one who is a real specialist of the model that you've built yourself. So how much are these models subject to prejudice, to bias, if it has such if human practice is so important in creating them?
Well, I would say that it's the case for any kind of science. It's always performed by humans, right? But maybe what is at stake is that there has been, as I mentioned, an evolution in the types of modeling practices. Like when you read the papers of 1927, it's just an equation that you can compute. I mean, you can write down the equation and follow the authors because you just write down the math. And the present day modeling are very much simulation-based, data-informed, so the importance of the data and all the management of data, and specifically when it's big data, requires know-how and computing skills, and so you don't publish the codes the same way you publish a mathematical equation. But of course, there's an issue here of transparency and capacity to reproduce the results that are embedded in the models, right?
Daniel Benamouzig, so you're a social scientist, but you're also a part of the scientific council related to COVID-19, the French Scientific Council, which has been created by the French president of the République. How much does your thinking rely on models? Do you take them a lot into account? How do you use them?
Well, they do provide very informative elements, which are certainly part of the discussion on the long run from the beginning, and it played certainly a role at the very beginning for the decision of the implementing a lockdown, certainly. But what I would like to make it maybe a bit more precise is that it is only one element in the discussion, and even if it is the sort of information that can structure some elements of a discussion, then comes many other elements. And if you consider the decision of the lockdown, as far as I remember it, and this very strike, and this very special day of the 12th of March last year. What happened basically is a mix with the data coming from models, and it was clear that those models were the very beginning of the exercise coming.
They were not so that reliable, right?
They were considered.
There were questions about their reliability.
They were discussed. They were considered as probably too pessimistic. And
were they too pessimistic in your view?
In theory, not that much, okay. But in practice, probably yes. So those were the very first elements on the table at that time, but they were mixed up with some other considerations, clinical considerations, information coming from Italy, informations coming from hospitals in real time, and coming from different scientific and clinical communities. And this was all this mix that finally could make an appreciation of these models possible within a wider discussion. Maybe if I may, I would like to ask you, Catherine, one question is how would you consider, or maybe you can say a word about that, about something that struck me very much is the way this community is playing their game quite collectively, even at the international level, not only by having sometime a shared training curriculum, but also by communicating very much one with each other, both at national and at international level. So how will you consider this kind of collective regulation of what is specific or what is the recipe, but with a very, as far as I perceive it, a high level of scientific exchange between them?
Yeah, I think not to reduce that to curriculum, I think it's also because it's a small community, right? And I mentioned that because of this specific history of epidemiology of infectious diseases after World War II. And in France, for instance, there are few centers compared to other kind of epidemiology, people working in epidemiology. So because there are a few groups with very influent one, you have many movements of researchers who go for a postdoc or for a year or two, and so people know each other very well. And when they meet in meetings, it's not very. I mean, it has become big meetings, of course, now, but it has for long been relatively small meetings. So people know each other, they practice, they compare, and this completely. I mean, it's not specific to this community. I mean, the community in which I used to work in genetic epidemiology was a small community and was exactly the same kind of practices. So I think that's the explanation.
So we have a few questions for you, Catherine Bourgain, coming from you viewers, and you can keep on asking your questions by, sending them by email using the Anses Symposium 2021 questions@anses.fr email address. Here's one for you. Should conventional infectious disease models, in brackets SIR models, be upgraded by taking into account social and economic aspects as well? Would that be possible to take into account those other aspects which are social and economic aspects? I don't know how it would be possible.
So in some ways, the new developments. In some ways, the new developments, some of the new developments have to deal with social practices, because it's a question of network, for instance. When people meet, do they meet? If they go to school, do they meet more? If they go to work, what's the distance from their home to their working place, and how long they stay in public transportation? So these kind of public social structures, they are embedded in the model. But generally, the model, and I think it relates to what Stefan mentioned about public health or dealing with bodies. It is a model that models the transmission of a virus. So you embed social interactions into that, but it remains a model built to do that, right? And this is not, it has not been changed for now, because it's the general framework in which the epidemics are captured. Doesn't mean that alternative models couldn't be developed, but I guess they will use different frameworks.
We had some very interesting discussions with some economists who use different kinds of model about the way of...
Within the scientific council, right?
Yeah, and with different scientific communities. And we had, with some experts, a very interesting discussion about the way of transferring even the codes of the epidemiological model in order to incorporate the effects on different economic values and aspects. And this discussion about the integration of both was particularly interesting. So probably there is a track to do so, a trajectory, and probably this epidemic will maybe change or displace the borders between the disciplines as it happens in such a moving context. And maybe another aspect is the fact that within these models you have a matrix for social contacts of different groups, which is in a way an image of the social life of those groups, which is clearly incorporated. It's not obviously only a biological dimension. This is the interaction between the biology and the human life, which is part of the story, of course.
So Daniel Benamouzig, you are our third speaker. In a moment we're going to listen to you, and afterwards we'll have a whole Q&A session with Mr. Hilgartner, Madame Bourgain, and Mr. Benamouzig. I will switch to French to hear you, because you're going to make your speech in French. Of course, it is translated for you, although your English is absolutely perfect. You could have done it in English.
I have to apologize because I didn't have that time to prepare my presentation, so I prefer to be a bit more precise in French than English. So I apologize for that, and then I switch to French pour vous remercier pour cette...
I'd like to thank you for inviting me to take part in this symposium. You're a sociologist, a teacher and a researcher. You're leading the health faculty at Sciences Po, which is the political science school, and you are also leading the School of Business and focusing especially on public health policies, and you are part of the Scientific Council COVID-19 set up following the request of Emmanuel Macron, and the aim of which is to enlighten public decision in the management of the sanitary crisis related to the coronavirus. You have 14 members to this council. You're one of them. This council has drafted 32 opinion papers and warning papers since mid-March 2020, and you're going to share your point of view on this experience. Thank you very much for inviting me to take part in this symposium to share this experience, which is very specific in the context of the current situation, but also gives an overview of the dynamics of the crisis with a series of elements which I'd like to share with you. They are related to knowledge, but also to doubt for many of these issues, and they develop under the topic of credibility, which is an issue which is of extreme interest because it is at the crossroad of science, decision-making, and society, and that is where the Scientific Council is playing its role, with credibility at the core of its work, credibility of expertise. This is not a comfort area, and sometimes we have to deal with a border between beliefs and science or scientific evidence. And I'd like to underline to start by underlying one point, that is the number of dilemmas that we are having to take into account when discussing, that we have to face, which means there is no simple solution. If you want to make sure you get it wrong, you simplify things, get rid of the dilemmas, and you will be making a mistake. So we're always assessing contrary aspects, whether the situation is necessary, is it new, is it routine, does it refer to something of the past, was it predictable or not, are the measures temporary or fit in time, is this an emergency situation or a long-term situation, is it about knowledge, lack of knowledge, certainties, uncertainties. We are facing all these dilemmas that are numerous, even on the particle front. That is the kind of discussions and debates that we had in the spring. And we could use some elements, for instance, asking whether it's something biological about the virus, is it something political having to do with the planning approach, the political planning approach. Well, of course, it's got to do with many of them, and that's what I'm going to try to do, to question these various aspects through various questions. And the first question, which is what struck me most during the past year, it's the importance of time and the time frame and the complexity in the relationship to this time frame when dealing with the issues at stake. Second thing, that is the extraordinary nature of this collective situation, with also the role played by this scientific council, which was very much questioned and discussed. And the third point, which closely relates to the topic of this session on credibility, that is the notion of mistrust, trying to open the black box of what is at the core of this black box. So the time frame, that's something that we can see through the curves, the modelings, the models. It's something we're used to, but in a way, that's what struck me most during the past year, during the crisis. It's the level of complexity of this time frame with various stages, but you have to be aware of what is a phase, a stage with exponential stages, and then getting back to a previous level. We have situations that we can look at objectively, but in which we're all involved, whether you're at the bottom of the curve or at the peak, or whether you are at a coming moment. You don't assess things in the same way. You don't assess what's at stake in reality, and we're all on these curves, like Russian waves. So it is a relationship to time which is complex. It's like a roller coaster. So as the Scientific Council, we've gone through different stages, especially in the way we played our role, and given the emergency situation, with a situation that was deteriorating extremely quick, then a latency stage, much more difficult, when we were wondering what was going to happen, that we had to wait for 3 weeks or maybe more, when we were going to see a decrease or an increase. The relationship to time changes a lot. We are faced with a situation that required quick, difficult decisions, as our chair was saying, the chair of the scientific council. So timeframes that are of a different nature, and at each moment in time when decisions were envisaged or different diagnoses were drawn up, there was the necessity to take into account these time frames, these various horizons and perspectives with long-term consequences. For instance, when we're speaking of interrupting access to school or having a series of young graduates not being able to access the labor market, we know that the consequences are going to be long-term consequences, and we had to assess these various dimensions and foresee under which conditions arbitration could take place and unfold. And more specifically, the position of experts about this was to say, for those who play this role within the framework of a scientific council, we need to get out of these time frames, the media time frame, the particle time frame, and try and have a more global vision and anticipate things that might happen on the basis of the knowledge we have. This is an interesting element, but it's only one. And what is interesting in terms of a time frame, which I thought was very exciting and sometimes challenging, that's this discrepancy between time frames with, on the one hand, the vision of experts with some who need to anticipate, and the public decision-making time frame, which is quite different in terms of speed of reactivity, but also in terms of impossibility. When we foresee a situation 2-3 weeks in advance, we assess the current situation, but for the public it is difficult to perceive this. And it's sometimes difficult to take a decision for something that's going to happen in 3 weeks' time and that nobody else is going to see or can see, and that is not going to be perceived as relevant. So you have to do this even though you deal with people who don't have this vision of what is at stake. So the different time frame of the media, the decision making, the public, the expertise, which are complementing the difficulty of this type of decision, which I think is what characterizes this type of issue. And I think it's important to realize this. So we are on the 12th of March in an impossible situation where we have to find a role for our council. Well, we came together on the 18th of March, but there was a non-formal meeting with other experts at the beginning of March. So it's really on the 12th of March that things are crystallized, so to say, and we start from a situation that appears as quite extraordinary in the literal meaning of the term. We deal often with ordinary things in the world of expertise. Scientific councils are many in the health field. We've had different issues that these health councils were working. For instance, in the case of the children who were born without arms, and the question was to find out what was the underpinning reason for this. Flores mentioned that, and now everybody knows what is a cluster. We have a certain number of rules with a group of experts, interdisciplinary experts, with the as a main concern improvement, producing advice. So this model, in a way, is closely related to expertise practices that are nothing exceptional and are often seen in the health field. We spoke of a model that was set up by the prince, but no, this is something that we could see in many countries where you have comparable institutions. I don't know whether this was, but I think the previous speaker actually mentioned the various models that were set up in the different countries. The modalities of depending on the country, is such that these council have an advisory role. I mean, this is not a decision-making one. It is an advice that's given on the basis of which some decisions are going to be taken. Nevertheless, as I've been part of some debates, there is a gap between what we discuss on the basis of our knowledge, trying to determine the various options available, and what is being implemented at other levels in terms of decision making. There might be deliberations between the two, but the rationales that underpin the one and the other are completely different. We have a rationale that's not a decision making one, neither an operativeness one. We would like some things to be set up, but it's not always the case. We see sometimes a gap and a lack of support. So you mean that you suggested some solutions that were not opted for? Yes, indeed, because there was, well, the means were not available for them to be implemented, and this is one aspect that will have to be discussed after the pandemics. Well, there's another element, that's independence. How far this council can be independent, given its setup and the way it was set up. Of course, well, the situation at the beginning is a bit tough because the issue of independence was not an obvious one. What we tried to do was to build it up little by little, advising the makeup of this, doing some advertisement on the makeup of this council, so that we have a diversity. For instance, in the UK, there was no public information on the makeup of the British Council. So what we did is we made it public. It was important not only for the government, but also for the other stakeholders in the field of health and public health issues. We reflect on what we think that we have to take decisions. Some issues are put through to us, but we think it's not our job. Then we also try to advertise in writing our opinions. Everybody can actually check the opinion that was discussed and see what were the elements that were taken into account and at which moment. So a whole series of rules that have nothing extravagant about them. They are traditional ones which make it possible to discuss, debate, deliberate. I mean, we have this in the public sphere in general. It's important also to know your place. That is to communicate without infringing on political time. And this can be built up also over time for experts that are not experts in public communications. Well, there's also another couple of issues that I'd like to mention. That's the certainties and the level of expertise at Anses. You know about this. We have aspects that are unknown, that are problematic, controversial, and dealing with this is the trade of any council committee that has to give opinion or take decision on these aspects. So once again, there's nothing fantastic about this. It's just the traditional way to do things. Then there is a multidisciplinarity between not only science but also social sciences. We have people who are not scientists. They are academics. They are or people from society, and we have also a high level of multidisciplinarity between the members of these groups. For instance, modelers are different from doctors, GPs are different from doctors working in hospitals. So it's important to have this plurality between the various ways to apprehend the issue, and therefore the role of the sociologist in this landscape is not so different from the others, from the other players. And this multidisciplinarity, it's not only about the difference between the 14 experts, it's also about the various communities which gravitate around the scientific council, and there is a convergence of elements that can be synthesized, metabolized through a specific build-up. And it's also not only about the academic world, but also the professional world or other players such as Anses. We can actually consult them on a regular basis or on an ad hoc basis. So this is a very strong role played by the multidisciplinarity. So that is an aspect that stabilized and became a full part of advisory bodies in the health sector. We have here a decision-making process about an issue that's nothing ordinary, but it's also about the way knowledge is made. But I'd like to get back to the issue of mistrust, which of course raises the issue of credibility. And it was said by Stephen Hilgartner, we are dealing with social spaces that have their own rules, often quite remote from the scientific world, from the spaces where knowledge is being produced from the world of decision making, and they follow completely different rationale. And one of them is, and that's not only true for the United States. It's true for our country. That's the political issues, or that is not only the policy-making issues, but the issue when it's at the heart of politics. And we've seen that it turned out that the head of government was discussing on an ongoing basis these health issues and what was at stake. And it's also part of the agendas of various political parties. So this political dimension, this partisanship, is not only what's at stake in the United States with the Democrats and the Republicans, but you can see that in different European countries. It is also at central level, sometimes the difference between the central metropolis and the regions, and we have a political dimension here. And this is about reality. I mean, this is about democracy, and it takes part in a debate, in controversy. So here we have political dynamics, and we also have the dynamics of the media.
Qui ont une très grande légitimité à parler en leur nom propre et de manière complètement libre, complètement indépendante, que ce soit des journalistes évidemment, que ce soit des scientifiques, que ce soit des médecins. Ce sont des professions qui disposent, on est très attentif à ces aspects-là en sociologie, qui disposent d'une autonomie professionnelle très forte, par construction. Et donc, d'une certaine manière, sur les plateaux, c'est la rencontre de ces autonomies professionnelles et qui, du coup, parfois autorisent les uns et les autres à prendre des positions qui, parfois, sont dans l'incertitude et méritent des formes de débat, des formes même de controverses, pourquoi pas publiques, et qui, parfois obéissent à d'autres logiques qui sont celles d'une forme de la régulation même des médias, selon des logiques économiques, selon des logiques d'audience, selon des logiques de la minute de publicité. Hein. L'audience, c'est aussi des rentrées publicitaires. Et donc, vous construisez des plateaux où vous allez pouvoir fighter, où vous allez pouvoir faire du buzz, et parfois au-delà de ce qui est raisonnable. C'est-à-dire qu'il y a un certain moment où les choses ne sont pas certaines, où il y a des hypothèses même minoritaires qui méritent d'être envisagées, discutées, de nourrir une forme de contestation. Et puis il y a des moments où on présente comme équivalentes des positions dont il est acquis à un certain moment, dans le consensus scientifique, qu'elles ne sont pas du tout équivalentes. Et donc là, il y a une forme de tromperie qui est problématique dans le cadre d'un débat qui implique et qui a des effets sur l'ensemble de la population. Moi, ce que j'observe sur ces
points of society, and this again is extremely important because there is an absence of bodies who are charged with regulating these different aspects. So once again, in the media, we haven't heard a lot of these, but things have evolved a little bit since then. There people who deal with medical regulations and even scientific institutions. We haven't seen a lot of them. They haven't been very visible in this public debate, and these are very difficult questions. So here we have the political sphere, the media sphere, who all run according to their own rules, who have their own logic, and which all are nourished by different areas and feed into one another and maintain this mistrust that we have a little bit. We'd also like to ask you some questions. We'd also like to have a debate with you. Let me just perhaps conclude by saying that there are these aspects of the media, perhaps institutional aspects, and then there are challenges and stakes linked to the dynamic more broadly that we see in the population. And these dynamics are characterized by divisions, very strong ones that become apparent at some times, and also things that were not clear at the outset, forms of compliance. Well, so yes, you believe in a consensus country. Well, it's not a broad consensus, but I think overall there is a form of compliance to the rules that sometimes even increases, even though there are pockets that are more problematic, that lead to situations that are difficult to manage. But we have seen this in a number of European countries, a number of other countries as well, in Italy, in Spain, and even in Germany. So we are in a situation in terms of compliance that is mixed. And the other point that I want to mention, which is really significant from a sociological point of view, and this I think is my role to introduce these in the Scientific Council, is to say that we are dealing with a phenomenon that is socially stratified, that there are different levels of exposure to risk and access to information and our relations, or people's relations with healthcare services, economic situation, different levels of impoverishment, of education, and so on. And so there is a dimension here in society that is deeply stratified, and that has to be examined and analysed very carefully to take into account these dimensions as well. And so to come back to where I started, we have these sometimes very lively debates, but we also have sequences of time frames and positions that evolve and are formulated and that are part of the public debate and that become stabilized over time. So those are the different points and phenomena that I wanted to raise and highlight without going too far. Right, so perhaps now we can switch back into English.
When you, in mid-March, when you started and when the council, the Scientific Council started working, do you have the feeling that eventually things were much more complex than what you thought they would be? Maybe we thought that we as a country were more prepared to this type of event than we were in reality?
Well, certainly it was something like a surprise for many people, and not only for decision makers, but also for experts and medical experts. And many of them were surprised by the situation, even in the mid-March, undoubtedly. Complex. There was certainly the idea that it will be something complex when you consider the immensity of the problems coming. But this was probably not the first impression. The first impression was, and it was not shared, was that it was serious, that it was very serious, that it was a very serious situation, and that it has to be managed as such. And this was what, in what consists this special moment, is the awareness of the seriousness of this of the situation, and ultimately the Italian situation make it much more concrete than the models and this kind of information which remain theoretical in nature, and which are controversial. And if you remember, we had also one expert in the place that was considering that this information was just bullshit, that it was very usual, that Neil Ferguson was in total mistake this time, like the previous one for the previous epidemics. Though there was a certain degree of uncertainty about the characterization of the situation. But I would say, rather than complexity, that it was the seriousness of the situation that was that we could feel very concretely in that moment.
You told us that the expertise that that is yours within the Scientific Council is the kind of expertise that can be found in other instances and other moments. It's quite classical, right? That's ordinary. But still, do the methods that you implement to create this expertise, do these methods change through time? Does it evolve? How does it evolve?
Yeah. Well, it evolves because you have more and more information, and you have more and more structured information when the time passes by. You have studies, you have data, so you can confront what at the beginning is mainly questions with some elements to answer these questions and to document this very often contended aspect of the situation. So there is a change between that. There is also a change if I compare it with the very beginning of the epidemic, of the management of the epidemic, as the fact that during a few days there was something, and it was really amazing and even shocking. There was all over the nation something like a complete silence about what was going on. There was no position, no institution saying a word about that. There was President Macron and the Scientific Council. It was very uncomfortable for us because we were very exposed to the general discussion. But at that time, you feel something like a profound loneliness in the situation for a few days. And then you have more and more data, more and more information, more and more contribution of different institutions that are coming in the management of the situation and providing new elements. And so over the time, the world would change according to the data you can gather.
Mr. Hilgartner, are you still with us? We haven't heard from you for quite a bit of time.
Yes,
wonderful. That's perfect. So would you accept to stay a bit longer, because there's so many questions and the debate is sure going to be very interesting. So if you can stay with us a little longer, it would be just fantastic.
That would be great. And I do have a kind of question for my fellow panelists, which, one of the things that I'm particularly interested in is the learning of lessons, from experience. And, in both of the arenas that you're discussing, the learning of lessons is something important to think about. I mean, in the area of science advice, one of the lessons that France has learned, and that is, I think, an important one, is to include social scientists and members of the public, the non-academics and so forth, in the process. And that lesson is, learned to varying degrees in different places. And in the area of modeling, the quote from Box perfectly sums it up. We have this sense that all models are flawed, and of course the answer to any in a learning situation to any problem with a model is to make a better model. In both of these areas, the solution to the problems is to improve the same mechanism. Once you're in the modeling mode, of course we need models. You're constantly in the game of trying to improve them, but there's always a lag. It's when you discover the problems, that you then are instituting the changes. And maybe a similar thing happens in some ways with science advice. That the things that you wish you had, you can't have on time. And I wonder sort of if you could comment on that and the sort of question of how we reflexively learn about this process of improving and learning from our inevitable mistakes and approaching our own knowledge-making reflexively.
Go ahead, Daniel Benamouzig.
Please, I will go.
Bourgain.
I think it's a matter of time, but not only of time, but developing new models. I mean, we mentioned how practical, how knowledge is something, a long-term perspective on what you can do and how you can imagine new framework or how you can imagine evolution of your model. So I think it's true that there is a process of, I mean, modelers have this idea that the good thing is when there's a flaw in your model, because then you will need to develop a new one or get new data, or, you know. But the question is, where are the directions in which you are practically able to expand and to develop, and we can't. So is it, and that's why I was trying to contrast two types of modeling practices, although they are not that different, as I mentioned, but it's because it depends on what seems important to you, how you imagine that you can develop your model. So I think there is this idea of improving that is always present. But it's important also to see precisely what kind of improvement are being made and what remains under considered because of practical reasons, knowledge reasons, but also a science perspective of the specific expertise of the people who are working on the subject.
Mr. Benamouzig, would you like to answer as well?
If I could just...
Sure, Mr. Hilgartner, go ahead.
Yeah, if I could just follow up on that. I mean, you know, it may be the case that the things that can't be readily added to the model are actually the things that matter most often, you know, and, you know, that might be one conclusion you could make from, you know, looking at how, for example, the politics of situations affects what happens in the public health world. And of course, those are very difficult things to model. So, you know, there's also an element of, you know, how do you inject into this process the requisite levels of humility?
Mr. Benamouzig?
Yeah, maybe a few words on that. This notion of learning, of collective learning, is certainly very important and very crucial in many cases. I would answer by saying that there is probably the collective learning of such a council, for instance, over days, over weeks, over months. We have this kind of routine that is coming, and the way of considering elements, of composing argumentation, of learning, also from politics. For instance, we experienced something very uncomfortable about the sort of instrumentalization of our advice on elections. It happened once, and the second time we tried to write it quite differently in order to avoid this kind of instrumentalization. So there is a capacity of learning within the scientific council. But what is maybe more striking is the fact that the collective learning is not only within the boundaries of the council, it's involving the whole society, which is learning the same elements all together. And this is, in a way, and especially when you're a social scientist, but it is also true when you are a physician and you consider the social landscape as well, is the fact that there is this collective learning with the measures, with the reflexes, with the knowledge, with what is at stake, and so the collective learning is not only the scientific part, is something much wider. And finally, the last element I would like to mention, it's very important and even strategic to have this learning. But it is also strategic not to learn too much. It's very important to be fresh, to have a fresh eye on new situations. If you have only the learning and the experience of what happened, you can really be in a very bad position, because there is an inertia of thinking, of considering things, of discussing problems, which is completely unadapted with what is in fact at stake, with something which is not a fellow citizen, which is something a bit more different and a bit more disturbing, which is a virus. And a virus we don't know very much. So we have to be very vigilant on this freshness of consideration. Not only learning, but learning with something else.
So I would like to take a few questions from the viewers that you just sent us. For instance, Mr. Hilgartner, according to your study, can you draw some conclusions about the consequences of setting up different competing scientific committees, such as the UK case that you mentioned with this SAGE committee and this INDI committee?
Well, I mean, I think at this point it's a little premature to say that, you know, that would have a sort of independent effect that you could imagine dropping into any society. You know, so you take a society and you say, okay, they've got one centralized thing. Now we add a second outside one. What's going to happen? I don't think we're in a position to do that. What we can say about the UK case is that the existence of that council is consequential in the way that understanding and development is in that setting is taking place, you know, and that it also reflects divisions in the country. So, but as to what it would you know, produce if you were to say, you know, suddenly add a contrary committee into another country that didn't have one, you know, I don't think that sort of prediction is a good something we can make confidently at all right now. It's more the sort of totality of how the response is developing that this is part of, and it, you know, it both reflects and amplifies controversy in the UK case that you have this independent SAGE arise.
Sure. Catherine Bourgain, are there standardization approaches and or standardized methods to select raw data and to upgrade models at the international level? Do you have standards to in order to upgrade models?
Well, as we just discussed with Daniel, the modelers, at least for what concerns modeling of emergent epidemic in linked with political or policy making and political decisions, is a relatively small and quite unified community, which means that people do exchange practices, codes, numerical codes, and and so there's a form of standardization, and also the data that have been used to refine the models, such as the transportation information or the census. These are data that have been standardized for quite a long time because it's administrative data or it's technical information that is really on a numeric format. So yes, this is a practice of comparing, and it's also a practice that at sometimes the same set of data can be shared and analyzed by different groups. Yes, but it's true that in the timing of the epidemic, there's the first one who's got the data and who's able to analyze the data is the first one to publish and to produce the model. So it's also science going on and a kind of competition because there's this publication issue also that's at stake.
Competition there, of course. Another question for you, Catherine Bourgain. Has the evolution of the pandemic confirmed the mathematics, predictive models eventually, or at least some of them preferably?
The problem, I think, is that the anticipation, the prediction that are produced by the model are dependent on the understanding of the epidemic, of the virus transmission, but also on the impact of the governmental or local measures that are taken. To what extent people really will wear the mask or will stay at home or will, and this is an issue of the models, to what extent they can capture what's going on, and when the model fails to really deliver prediction that are, I mean, when prediction do not meet reality, it's difficult to understand to what extent it's due to this or the other parameter of the model.
So there was a question about the media role, Mr. Benamouzig. Would you consider that French media played an effective role in informing population, meaning in circulating decoded scientific information? Are we not missing these information brokers that have been cited yesterday? Yesterday we had Altwin Ren who said, okay, it would be fantastic to have what we call scientific or information brokers that would be totally independent and that would be able to, you know, cross information and to, you know, draw some conclusions, reasonable conclusions about various scientific questions.
Well, you have very unequal situations. They did an incredible job, really, because day by day they could decode so many complex issues and informations for so many countries, and so they did a very amazing job, really. But with a very unequal situation, and probably this is not the same media who played the role of making this kind of translation, of brokering of science to the public on the one side, and proposing something like more like a show on the other side, and with different rules, very far from what is considered as science, whatever the meaning you can associate with the word. So they are very unequal situation. Maybe one point to be emphasized about that is probably the weakness of the scientific press, of the scientific media themselves, and probably the situation is clearly not very satisfying in France, but in many other countries, and this is unfortunately probably not only the case for science, but in such a situation we paid it cash because there were not so many professionals that had the contacts, the culture, the competence to do this translation in real time and to providing the information on the TV media especially, and so on and so forth. So there is certainly an amazing job and a weakness in the meantime.
Mr. Hilgartner, there's a mystery that has to be solved. Here it is. I just took a look at the figures yesterday, and we have 1,050 deaths per million people in France. So that's 1,050 deaths per million. Although we had 2 lockdowns, we have a mandate on wearing masks. We have a curfew at the moment, which starts at 6 p.m. every day in the whole country. So we truly had to make a lot of efforts. And on the other hand, so that's 1,050. And on the other hand, in the US, we have 1,200 deaths per million people. So that's just a little above, not so much. And it seems, as seen from France, that you know, you didn't have these big lockdowns. You don't have a mask mandate. So how can we explain this these figures, which are not, you know, so different one from the other one?
Well, I think that the key thing in the U.S. is that there was a variety of different policies followed in different places, and you know, so that's one critical element. Another is that, you know, when we're classifying one as a chaos country and one as a control country, you know, that's looking at all 3 of the arenas: the politics, the public health, and the economy. And, you know, there I think we see a very substantial difference. And I think it's important not to focus on any single indicator to judge policy success. You know, if you were to just use these numbers, deaths per million, or you know, then you're going to get one kind of an answer, but it's a very incomplete picture, and it doesn't capture the amplification of social conflict, and it doesn't capture you know, the descent of large numbers of people into poverty and an ongoing debate about whether the recovery in the United States is going to be V-shaped in the sense that it goes down and then it goes back up for everybody, or K-shaped, where there's a recovery for some and continued decline for others, which looks like a very likely direction for things to go. So I guess I would say that the big question is, which indicators matter? Why do they matter? And what are the politics of selecting one indicator versus another? And of course, that also relates to the policy questions. If we only are looking at an issue like lockdowns, then you're looking at a limited part of the world as compared to if you look at what is being done to, say, facilitate economic recovery and other elements of the total system.
Okay, we'll stay a bit about 10 minutes more together if you wish. Catherine Bourgain, we have other questions like, considering the lack of consensus and personalization of model experts, would a classification or a typology of these experts be possible? So someone is advocating for classifying experts.
Well, classification is always a very touchy process, right? So
sure.
I'm not sure that will be that possible, in the sense that, again, I'm coming back to this rising of big data and the fact that although you might have the feeling that some groups, they have different approaches, theoretically, then you have, because of this rise in data, you have some kind of leverage in the differences, because they can stand from different perspectives, but given the type of data they're using, the differences are getting smaller. So, yeah, of course, it's important to have an insight on the different kinds of hypotheses and ways of modeling, but I don't think a simple categorization is really possible. But of course, my point was precisely to say we have to understand better what they are doing and what they're not doing, to have the models at the right place, which is something helpful in specific situation, not always. And the more we understand, the more we are able also to foster the diversity of types of modelings and the kind of issue that finally enter the modeling, the better these tools will be for decision making. Although, of course, they cannot be the only tools.
Sure. Mr. Benamouzig, do you have the feeling that now France would be better prepared for another sanitary crisis such as this one? We've seen that Taiwan was able to tackle the crisis very well, and many people say that because they experienced an enormous virus outbreak with the SARS virus, that it was in 2012, if I'm not wrong. So would that be the case with France as well, do you think?
I really don't know.
Really?
We have now this kind of experience. This is something which is actual, which is real. We have this experience. We have probably not only to learn over time, but also to draw some lessons that are to be drawn.
What lesson, for instance?
We have some degree of weaknesses in different
okay, what did you learn?
What did we learn together? You mean, well, maybe the awareness of this kind of situation. It can happen, and probably it will again happen. And now we know that, and so we know what is at stake in such situations, and we know that not only for health issues, but also probably for environmental issues, and this complex cycle with experts, population, changing situation, systemic effects, huge economic consequences. It's something like an experience, and probably we have learned something, but I think that we need time to know what we have learned.
We need time to know what we have learned. What have we learned, Stephen Hilgartner, according to you?
Well, I mean, I think one thing that, in relation to this question of whether France will be better prepared next time, that we can ask is, you know, is there a danger, that that will always be, as they say, learning the last war, fighting the last war? Clausewitz, the great theorist of war, writes that the most important and far-reaching act that the commander or politician, statesman has to make is to establish what kind of war is being fought, and not mistake it for being something else, and not try to turn it into something that it isn't. In the battle against the pandemic in almost all the countries that we looked at, war metaphors were being used by the heads of state and other people high in the policymaking apparatus. But what kind of war they envisioned it to be actually, varied from place to place. So Taiwan could fight SARS because this was a recent, kind of collective historical experience. For Germany, there's been not since World War II a battle that requires the kind of joint action or solidarity. In India, the Prime Minister Modi, pursuing his Hindu nationalist direction, read the case in terms of one of the great Hindu epics, turning it into a war that the whole country would fight for 3 weeks. So the learning takes place in a socio-political context where the ways that societies understand themselves plays a very, very important role. And I think that sort of a little reflection and understanding about that can help deal with some of this in terms of helping us to at least think about and hopefully do better in not making the same mistakes because we try to rerun an experience, which may work really well as it did in Taiwan, but in other situations, maybe not so much.
And Stephen Hilgartner, in your report, you write that disease found and revealed salient weaknesses in global institutions. To confront another such crisis in the future, global institutions will have to be reimagined and even reinvented. What do you think of? What should these global institutions look like in the future?
Well, I mean, I think that if we were to take one of the, emerging problems that we're facing right now at the global level is, vaccine nationalism. And obviously, we are entering into a situation where poor countries, low-income countries, are going to benefit least, have the longest lags before they get the vaccine. In the case of Peru, for example, a political crisis there led to a situation in which they didn't place orders for vaccine, and it looks like they may not receive any vaccine, and not in 2021, but even well into the next year as a consequence of that. Now, this, as the Director General of the World Health Organization and others have pointed out recently, represents a moral crisis at the world level. And, it's not being, at least right now, dealt with. And so, that kind of thing we should be taking into account. In the longer run, we need to be thinking about how to strengthen the global response to pandemics. If we think of it as a situation where, just as in Singapore, the least privileged part of the population is where the disease was most prevalent, this situation is quite possible, to occur at a global scale again and again if we don't address it. And it is a pandemic and it affects everyone, and so a global response is needed as well.
Mr. Benamouzig, do you have the feeling that there's so many other crises that are coming? I mean, water crisis, climate crisis, biodiversity crisis, and so on. And was this, which involve economic problems, social problems, migration problems, and so on. In the future, do you have the feeling that all of this was just a rehearsal of what is coming?
I don't know if it is a rehearsal, but certainly we have to consider this possibility very seriously once again. But I would like to add a word, because to what just said Stefan Hilgartner, this is not only a question of a moral crisis in terms of judgment about social inequality and about global justice in public health, which is clearly a very important issue. But it is also just a question of effectiveness. If you consider the importance of the mutations of the virus, it happens in South Africa, it happens in Brazil, it happens in countries where you have very specific health situations with immunodepression, for instance. In South Africa, where you have a situation of a high level of prevalence in South Africa and Brazil as well. And so this is the places where the mutations that will finally provoke a very high danger for the whole planet that will happen somewhere when it happens. So we are in a situation of solidarity, not only because of moral aspects, even if it is important, but also because of health, biological, and this is another aspects in which all those aspects are very mixed in reality, and biology is not separated from humankind and human values. It comes together, and so we probably have to be more aware on those aspects in the coming times.
So it's really an incredible moment that we're in because of this COVID-19 pandemic crisis outbreak. Let's hope it's not just a rehearsal for other crises to come, but it was very interesting to see how the experts and decision makers came out with various responses to this crisis in each country. With Mr. Hilgartner, we had an insight in the world of models with Catherine Bourgain, and in the French Scientific Council with Mr. Benamouzig. So this was the second day of our Credibility of Science, Expertise and Decision Making Symposium. Thank you for watching. I should remind you that there are workshops that you can attend in January and in February. Thanks for watching and have a very nice evening. And thanks very much to the three of you. Thanks very much, Mr. Hilgartner. Bye-bye.
Thank you.
Thank you.
Thank you.